Welcome to the ICU Management and Practice DigiConf Organ Support. Our Editor-in-Chief, Professor Jean-Louis Vincent, will moderate the session. Our panelists include Wojciech Szczeklik, Jagiellonian University Medical College; Marta Velia Antonini, University of Modena and Reggio Emilia; Alessandro Pelletti, IRCCS San Rafael Scientific Institute; and Pablo Galindo Vallejo, Medical Center ISSEMYM Ecatepec. Let us now welcome the moderator for today's DigiConf, Professor Jean-Louis Vincent.
Hello, and welcome to everyone. Thank you for being with us. Sorry, we had a slight technical problem here, but we are ready to go, and we are very happy to welcome our four speakers who were quickly presented to you, introduced to you. And so, since we are a bit late, I will go right ahead, and I will invite Dr. Wojciech Szczeklik to present the first aspect, which is the frailty leading to organ failure. And Dr. Szczeklik is from Kraków, of course, in Poland. So welcome, my good friend. You have 10 minutes to present your talk.
Mr. Chairman, ladies and gentlemen, thank you very much for this invitation. I have no conflict of interest with this presentation. And as for beginning, I would like to start with actually showing the magnitude of the problem. As we all know.
We don't see your slides, huh?
Again. I don't know why. Apologize.
Did you push on share screen?
Yes, it's all done. And just a second. I think it's not actually me. Again, yeah.
So can we get the technical support? Okay. Now it's coming up. All right.
So the magnitude of the problem. So as we all know, the global life expectancy is increasing worldwide, and we expect actually the population of people above 80 years of age double by 2050. So it affects all the medical field and especially actually intensive care medicine. And we all know also that age alone is not a good predictor of intensive care treatment effects, survival, or long-term prognosis. So we need to find something more. And more important are accompanying problems as multimorbidity, cognitive impairment, and frailty. There are several definitions of frailty. I chose one by Chen from 2014. And it's decreased physiologic reserve that increases vulnerability to acute stressors. It's actually very similar to the one used by WHO. What is important is to stretch out and say it loud that it's not the same as age. Frailty is not old age. However, of course, with age, frailty is much more common. It's due to the decreased mobility, sometimes weakness, sarcopenia, malnutrition, or impaired cognition. To assess the frailty, we required validated scoring systems, and all actually the scales that we use were validated in people above 65 years of age. There are several of the scales. The gold standard is the comprehensive geriatric assessment. However, it's quite difficult, time-consuming, and not for intensive care. So there are others like Frailty Index, and the one which actually I would recommend and talk about is a clinical frailty score. So frailty is actually, it never comes alone, almost never. So alone, it can be found about 6% of patients. But as you can see, it actually coexists with comorbidities, cognition, daily life impairment. So it's a geriatric syndromes that coexist all together. When we talk about organs, of course, we always think about SOFA. It was recommended and actually invented for patients with sepsis, but we use it broadly now to all kinds of patients on intensive care, assessing the organ function, starting from circulation and dealing with ventilation, neurological, renal coagulation, and hepatic disorders. However, when we talk about old patients, it's not a good discriminator between old and young, and actually does not add so much new information alone. This will be similar scores if a patient is 85 and 30 and comes to intensive care in a severe state. So actually Frailty adds a new information. And the scale I would like to discuss, it's called Clinical Frailty Scale, CFS, invented and introduced by Dr. Rockwood in 2008. And 3 first grades, this is the fit patient. So a patient, as you can see, he can run, or he or she can run here, at least cope very well at home alone. And this is a pictographic scale and a short description, so quite easy to use. Number 4, it's something which used to be called vulnerable patients. So on the border of being frail, some activities are actually already dependent on other person. Not everything can be done on their own. And 5 to 8, this is the frail patient. And of course, as you can see on the pictures, it's like it's going down and down. And actually 9 is terminally ill patient, whom we actually hardly ever admit to intensive care. A good thing is that it's an easy index, easy scale to use. And we've done a study checking the inter-rated variability with CFS, almost 2,000 patients on intensive care. And you can see highlighted in yellow here that among physicians, the weighted kappa was 0.87, even better with nurses, 92. And it did not depend on, like, did we take the history from the patient, family, or hospital records. So easy to use scale. However, one important thing is, like I already said, it's frail or fit, but it's much better to use the scores alone and not simplifies or categorize. So if we look at these graphs, and on the left side, we have odds ratio for death in intensive care, and on the right side death at 30 days, you can see that with every point, the mortality, the risk of mortality actually goes up. It starts really high at about 7 or 8, whatever kind of regression analysis we use. So it's with every point you add the risk. However, if you use a simplified score, which is just vulnerable or frail, the one here in violet, is actually underpowers, underrates the risk. So it's better to use the scores. And it was also recently proved in a large meta-analysis of individual patients' level data, over 20,000 of patients on ICU. And you can see the survival rate, the highest line, it's CFS of 1, and the lowest is CFS of 7. So you can see this line spread and easily show that it's not good to be in this CFS of higher grade. And actually, the CFS of 7 has a mortality of around 70%. So it's really, really a bad prognosis. So the meaning of frailty, based on the literature we have, is it's actually common. And CFS of 5 is found in old patients above 88 of years on ICU in 46% of patients acutely admitted to intensive care. And if every single point adds actually 11% of risk to the prognosis of 30-day mortality, so hazard ratio of 1.11. Frailty itself contributes up to 9% of new prognostic information about 30-day mortality after adjusting for basic patient characteristics, including SOFA. And higher frailty, it means also higher requirement for organ supports and more commonly life treatment limitation decision. Of course, it's not only about the points and single one index, and we recently performed an analysis published in intensive care, which was trying to find clusters of patients that actually prognose similarly. And we found 7 clusters, A to G, and I just would like to point on this G and A. So G is actually a patient where It's a combination of geriatric profile with a substantial degree of organ failure, so high SOFA. And actually the mortality here, it's above 50%. So if you take A, which is a patient not being frail and with a lower SOFA, the mortality is less than 10%. So it's not about the age, it's about like all the factors together that gives you the prognosis. So to sum up, and this is a pictorial from our work in intensive care from last year, it's when you have a patient admitted to intensive care, you of course take age, comorbidities, acute illness severity, all the data you can, and you try to assess the frailty. Frailty need to be measured. I would recommend the clinical frailty scale, which is easy, just discussed. And then you have to interpret it. Here we pictured actually fit or frail. However, after new data, after using it more commonly now, I would recommend the sole points, not trying to say fit or frail, just say 6 or 7 points. And finally, all of this you take into account in decision-making, end-of-life decision, maybe time-limited trial, advanced care planning, or rehabilitation, further geriatric unit. So the take-home message would be that frailty should be regarded as one of the predictive factors of the ICU trajectory. CFS is a simple tool, and the frailty should not be diagnosed as present or absent. Different grades of CFS have different prognostic implication. I would be aware of 7. It's a really bad prognosis. Always, however, take into account the whole picture, patient-centered medicine and phenotype instead of scales. Thank you very much, and I will be happy to answer your questions. Thank you.
Very good. Thank you very much, Wojciech. That was a very nice summary of the importance of frailty. We will certainly have some questions soon about how to use the score practically. But I think your presentation was indeed very clear. Let's move on as our time is limited, and let's invite Dr. Marta Velia Antonini from Modena to speak about ECMO. Marta Velia, that's another very important topic, of course. You can share your screen if you don't mind.
The previous speaker. Okay, perfect. Now I'm.
Yes.
Previous speaker needs to stop. I need the previous speaker to stop his sharing.
Yes,
okay,
I can.
Perfect. Thank you. Thank you. Okay.
Here we go. ECMO support.
Perfect. I am a perfusionist, so I'm going to talk a little bit from a technical point of view of main configuration of ECMO support in critical ill patients, and I'm going to talk also about their physiology. I have no conflict of interest with referral to this topic. So these are the 2 main categories of extracorporeal life support for the critically ill. We talk about ECOR, meaning extracorporeal suture removal when you have low flow extracorporeal life support. For ECMO, we need high flow extracorporeal life support. The 2 main categories, the 2 main configuration of ECMO are VA and VD ECMO. The first letter refers to the site of drainage. The second letter refers to the site of return. So for VA ECMO, we drain the blood from a vein and return the blood to an artery. For VD ECMO, we drain the blood from a vein and return the blood to another vein. With VA ECMO, we provide circulatory support, which is not cardiac support, and we are also able to provide oxygenation and carbon dioxide removal. With VD ECMO, we provide oxygenation, we provide carbon dioxide removal, and the level of the support that we are able to provide to the patient is proportional to the level of support that we need, meaning that ratio between the extracorporeal blood flow that we are able to provide in that particular patient and the cardiac output of the patient. With VD ECMO, we do not provide direct circulatory support, but considering that the pulmonary vascular resistances are going to decrease on VD ECMO because of the oxygenation, and that we are going to be able to decrease the intensity of mechanical ventilation, the right ventricle will be happy. So it's going to be able to better support, to better preload the left ventricle. Moreover, we are going to decrease the oxygen demand of the native lung, and we are also able to increase the myocardial oxygen delivery. So we could say that with VV ECMO, we are able to provide an indirect circulatory support. And that kind of support could be enough for a mixed scenario of lung failure, severe lung failure, and severe respiratory failure with hemodynamic impairment. So sometimes VV ECMO, for example, in septic patient, could be enough. Let's go in detail in this kind of support. These are the main configuration of VV ECMO, which are femoral-jugular VV ECMO and femoral-femoral VV ECMO. We drain from the femoral vein and return with a cannula inserted in jugular vein and with the tip in the right atrium or at the superior vena cava, right atrial junction. The drainage cannula is usually really long and have multiple holes for drainage and is able to drain at different level in the inferior vena cava. For femoral VV ECMO, we drain and return the blood through cannula inserted in both the femoral veins. The site of return is exactly the same. With double site VV ECMO, you need to consider a potential complication, a potential scenario that is named recirculation, meaning that the part of the blood of the oxygenated and decapnized blood that you return to the patient with your extracorporeal circuit is withdrawn by the drainage cannula. This is going to decrease the effectiveness of the extracorporeal support. So you need to keep this recirculation fraction really low. Sometimes you have an increased recirculation fraction, particularly if you have really high flow with really low drainage pressure, so really negative drainage pressure, or when you put the drainage cannula and the return cannula too close to each other. So you need to consider this kind of complication when, for example, you have really high perimembranous lung saturation on your extracorporeal circuit, and when you have persistent hypoxemia on VV ECMO. This could be one common scenario. We could also provide ECMO with a single cannula for VV ECMO, which is the double lumen bicaval cannula. You have one lumen for drainage, draining both from superior vena cava and inferior vena cava, and you return the blood with the same cannula at the level of the right atrium, just above the tricuspid valve. If this cannula is properly provided, you are going to have the lowest recirculation fraction feasible on VV ECMO. With this cannula, you could not go too high with the flow, but in some patients could be absolutely enough. And with this cannula, with the single cannula, having the both femoral veins completely free, you are going to be able to better provide the rehabilitation, active rehabilitation in your VV ECMO patient, particularly for maybe awake patient waiting for transplantation. So it could be a smart solution. Another kind of double lumen cannula that you could use for ECMO is the veno-pulmonary cannula. Again, one cannula both for drainage and for return. This cannula is able to provide not only oxygenation and carbon dioxide removal, but also direct circulatory support, because you bypass completely the right ventricle, providing a direct flow into the pulmonary artery. Let's go to peripheral VA ECMO. Peripheral VA ECMO is most commonly performed drawing blood from the femoral vein and returning the blood through the femoral artery. The main data that we need to say about the peripheral VA ECMO is that we provide the blood returning retrogradely into the aorta. A different configuration is the femoraxillary VA ECMO. We provide a flow of returning blood, no more retrogradely, but antigradally into the aorta through the axillary axillary artery. Sorry. This configuration is still not so common, but could be a really good option in some patients. With peripheral femoral VA ECMO, the most common configuration, you need to consider a concept, which is the mixing point, which is the point in the aorta when you could have the mixing of the flows from VA ECMO, from the extracorporeal circuit, and from the native heart, if the native heart is ejecting. If the nativart is not ejecting, the blood from the ECMO are going to provide the perfusion of coronary arteries, of neck vessels, and peripheral perfusion. But this is not what we want in ECMO, because we want to provide support to the patient, but we also want to promote nativart recovery to avoid left ventricular overload and to avoid a series of potential complications like thrombosis in the left ventricle and the aortic root. So we want the nativart to eject. And when you have the nativart ejecting, you have this mixing point at different level into the aorta, depending from the power of left ventricular ejection and depending from your extracorporeal blood flow. This could be okay if you're able to win the patient, and this is okay if you do not develop pulmonary complication. If you develop pulmonary complication, you could have a phenomenon named differential oxygenation, with the blood from the nativart with low oxygenation and high partial pressure over carbon dioxide. And this is not good for the coronary circulation and for brain circulation. The level of the mixing point is going to characterize the level of the differential oxygenation with the upper body of the patient mottled and not well perfused compared to the lower part of the body. When you have this kind of complication, you need to provide alternative configuration of ECMO support if you are not able to improve the oxygenation and the carbon dioxide removal with mechanical ventilation and eventually proning. So you maybe need to provide a central configuration of VA ECMO, or maybe an auxiliary configuration like previously said. But an alternative solution, if you are in an experience center and if you are not able to fix the solution with mechanical ventilation, proning, or if you are not able to win the patient from VA ECMO and convert to VV ECMO, is what is called hybrid ECMO, meaning two returning lines, two returning links for the circuit, both in a vein and in an artery. So a VAV ECMO, providing both circulatory support and respiratory support. It's a complex, definitely a complex configuration because you need to manage the flow flowing from the circuit through the venous limb and through the arterial limb, modulating the resistances in the venous, particularly in the venous side, because normally you have resisted resistances, so all the flow is going to try to go to the venous return. Another potential complex configuration of extracorporeal support is the double drainage configuration. That is something that we do both for VV ECMO, for VA ECMO, but also for hybrid VAV ECMO, when you need to improve venous drainage to increase the flow. It's the sometimes that experience center do often. Again, the more complex is your ECMO configuration, the more complex is the monitoring that you need to perform in your patient. And I think that my time is finished, so I'm here if you have any question.
Thank you very much, Velia Marta Velia. That was a very nice overview. And we will certainly have a question at the end. But let's move on from the heart and lungs to cardiovascular support with Dr. Alessandro Belletti, and we will stay in Italy as he is from Milan, and he will discuss primarily the vasopressor inotropic support. May I remind everyone, we have almost 150 participants from all over the world that they can ask questions via the Zoom system. Just go to the Q&A section and write your question. Okay, Alessandro, we are looking forward to your presentation.
Thank you very much for the invitation. Can you hear me? Can you see my
very
slides?
Well.
So, first of all, thanks for inviting me to talk today. The point I will go on from my presentation are here summarized. I will try to convince you that low-dose catecholamines and norepinephrine in particular remains the first-line agent to be used in mass shock context. We have to remember that inotropes and vasopressor do have side effects, and so it seems wise to use this drug at the lowest possible dose for the shortest possible time, it seems reasonable to combine agents of different classes to limit individual dose and side effects when doses becomes too high. And also that identifying and achieving correct hemodynamic goals is probably more important than the molecules you use to achieve them, always keeping in mind that different patients may have or may have different needs. And so individualized approach remain a key issue also in use of inotropes and vasopressor. I will start with a question that was answered may seem obvious. However, we should remember that there are several observational studies now that suggest that inotropes or high-dose catecholamines may actually increase mortality. Intuitively, there is no RCT comparing inotropes and vasopressor with no treatment at all in unstable patients. But we have some indirect evidence from randomized trials comparing higher versus lower hemodynamic targets. And generally, here there are a few examples. These trials show that higher hemodynamic targets, such as higher blood pressure or higher cardiac index, are generally not beneficial and maybe in some cases be harmful, potentially because of greater exposure to inotropes or vasopressor. And on the contrary, some recent trials even suggest that accepting lower hemodynamic targets, for example, by limiting vasopressor dose, lead to comparable outcome as compared with usual care and may actually be beneficial in some cases. Now, what does evidence comparing different vasoactive agents generally show us? I have a few examples. There's been several studies in the last years, and they do generally show common patterns. This is one example, vasopressin versus norepinephrine in septic shock. This study shows that patients receiving vasopressin and norepinephrine achieve similar mean arterial pressure level, although patients receiving vasopressin, of course, require lower dose of norepinephrine. There is no difference in survival, but there are some differences in side effects, with patients receiving vasopressin having less arrhythmias, but more digital and bowel ischemia. Another study compared dopamine and norepinephrine. Again, no difference in survival, but more adverse events with dopamine. If we move to inotropes, we can show some examples. Studies on levosimendan has been a largely investigated inotrope in the last 30 years, several large MRCT multi-center controlled trials in several settings. And collectively, all of these studies show that levosimendan does not improve survival. It does not improve major outcomes, although it reduces the need for concomitant inotropes. It does not increase major adverse events, although it increases the risk of arrhythmias and hypotension, and is generally not superior to catecholamines, with the potential exception of patients on chronic beta blocker. Another example is angiotensin II in vasodilatory shock. Again, the study shows that angiotensin effectively increases blood pressure, mean arterial pressure, and reduce need for concomitant norepinephrine dose, with no major effect on survival, although we should acknowledge that this study was not powered to detect such differences. However, just be careful that there are also studies showing that if your hospital run off of norepinephrine, mortality of patients admitted during that period, even if treated with alternative vasopressor, may increase. So collectively, since that these studies show that overall, in an overall unselected population, molecules by themselves do not seem to affect survival, although it's always better, seems better not to run off of norepinephrine supplies, that different molecules have different adverse events profile, especially at high dose. And there are some studies now suggesting that conservative hemodynamic targets, meaning lower exposure to vasopressor and inotropes, may actually be better. And this might, for example, challenge the view that we should, in any case, maintain, for example, a MAP greater than 65 at any cost. And so, for future direction to optimize inotropes and vasopressor support in critically ill patients, some authors suggest a different approach. We know that the response to the different agents may be different in different patients and is frequently variable and non-predictable. And so we may decide to start patients on different drugs to limit the dose of each agent and to assess the individual response to each different agent, and then titrate the dose accordingly. This is just to show you that we already know that, for example, there are patients who respond, patients do not respond, for example, to vasopressin or to angiotensin II, and the same also happens with catecholamines. And responder and no-responders do have a different outcome. We now also start to have some data or some evidence that we may actually be able to predict those, to start to identify patients who will have different response to different vasopressor. For example, this is a secondary analysis of the ATOS-3 randomized trial on angiotensin II that show that patients with low renin level do not show difference in certain outcome when randomized to placebo or angiotensin II, whereas patients with higher renin levels may have a better outcome if they receive angiotensin II as compared with placebo. So, to summarize again, my point of view on inotropes and vasopressor, they are that if you start with low dose norepinephrine, will not be wrong in most cases. Remember that inotropes and vasopressor do have side effects, and that conservative hemodynamic targets may be better in some cases. Combined agents of different classes may limit side effects and may improve the possibility to individualize therapy. And identification of hemodynamic goals, identifying target hemodynamic goals in individual patients may be more important than the molecules you use to achieve them. Few words for future direction. I think that future direction in this field will be to identify optimal hemodynamic targets, to identify optimal timing to start and stop vasopressor treatment, to identify predictors of response to each individual drug, and also, especially in the setting of cardiogenic shock, there will be probably room for investigate the role of mechanical versus pharmacological support. So thank you very much, and I will be happy to answer to your question later.
Grazie mille, Alessandro. Very good, quick overview of a very complex topic. And indeed, we will have one or two questions later. But after the lung and the circulatory support, we will go for the kidney. And Dr. Pablo Galindo Vallejo from Mexico will discuss what we call now kidney replacement therapy or renal replacement therapy in the ICU. So let's see what Pablo will tell us about it. You are welcome, Pablo.
Well, thank you for the invitation. I'm very glad to be here with everybody. So today we're going to talk about kidney replacement therapy in the intensive care unit or renal replacement therapy. Okay, I have no financial disclosures. And let's start with this. We know that patients in the ICU that have acute kidney injury and also need kidney replacement therapy have a very high mortality. Okay, we have found this constantly through decades. Okay, and for the last 2 decades, many efforts have been done to try to reduce this mortality. You know, we have tried with dose, we have tried with timing, even we have compared different types of therapies or even modalities inside of the type of therapies, and mortality and survival has not moved a lot. Okay, so then if we're not searching for a target like survival, then what should be our target when we do kidney replacement therapy? Okay, so for most patients in the ICU with an urgent indication of kidney replacement therapy, the main target should be first, fluid balance and solid control, like small toxins, small solids that can be removed and can put in danger the life of the patient. Okay, so this should be our first priority when we do kidney replacement therapy. And while we are doing this, we have to think that our therapy is not gonna kill the patient. So we have to think about hemodynamic stability. We have to think about heart stunning, about intracranial pressure, kidney recovery, drug removal, or even nutrition with patients while doing the therapy, okay? So we can divide our therapies in three main groups, okay? We will have the intermittent kidney replacement therapies. We will have the continuous kidney replacement therapies, including peritoneal dialysis and all the modalities that we know of kidney replacement therapy. And we will have something in between that will be therapies that will try to emulate or continuous therapies or intermittent therapies. We will have the prolonged intermittent kidney replacement therapies that are therapies that will try to be like continuous therapies using intermittent technology. And we will have the accelerated therapies that we're gonna try to be more like intermittent, but using the technology of the continuous kidney replacement therapies, okay? So to understand the similarities and to know how to prescribe these therapies, we have to know or understand small solid kinetics and operating characteristics of each of the therapies. Okay, so this is a very nice example of how can we understand this. If we define the therapies using Clarence, especially the word efficiency, we can describe therapies that are highly efficient and therapies that are very, very, very low efficiency, that have very low efficiency. And obviously, hybrid therapies will be in between, okay? So when we classify by efficiency, we can see that they are very different. But when we multiply or do the product of Clarence by the day or the time of therapy that we have, we can call this intensity. We can see that the therapies can be very similar. Okay, so very low efficiency therapies can compensate with time. Okay, and very short therapies can compensate with efficiency with Clarence. Okay, so this is an image that we can see where we can see intermittent therapies are very efficient therapies with very low intensity, and continuous therapies are very intense therapies that go through days, and in between we can find hybrid therapies, okay? This is how we will see the small size solid removal and fluid removal with different types of kidney replacement therapy. Here we have a healthy kidney that will be always in steady state. Here we have a conventional hemodialysis or intermittent hemodialysis where we have an initial high efficiency therapy with then a rebound of solutes and fluid accumulation. And then we have to repeat the therapy to get to our goals, okay? So we will have a SAW image like this one, okay? Hybrid therapies will have the same high efficiency or intermediate efficiency therapy with a secondary rebound, and then we will have to repeat the therapy. For continuous therapies such as peritoneal dialysis or extracorporeal continuous kidney replacement therapy, we will have a very, very slow slope and very low efficiency of the therapy with finally a steady state very similar to what we have in the healthy kidney, okay? So this will be how it will look for small solids and fluid removal. But considering this, we will have special considerations. It will be smart to use one or another therapy, not always every therapy. So we know now that survival will not be different with any of these therapies. We know that kidney recovery, there are some observational data that tell us that maybe peritoneal dialysis and extracorporeal continuous kidney replacement therapy can be better with kidney recovery, okay? There's a kind of controversial side, but this could be true, okay? Hemodynamically unstable plus fluid overload, although therapies like these will be very easy to manage these patients, it's not impossible to manage patients that are hemodynamically unstable and have fluid overload with conventional hemodialysis or hybrid therapy. It's completely feasible, and it's only It's only you have to accommodate or adjust parameters to to do that to your patient. Okay. There are some special considerations that are very important and should always be considered. Okay, increased intracranial pressure. It always be better to use continuous kidney replacement therapies instead of intermittent therapies. Okay, free machine time is very important, especially if you have many patients with the same requirements and you need many machines, or your patient needs to move to a study, needs rehabilitation. So free machine time can also be considered, especially when you're doing continuous therapies. You have to consider that your patient has to be or remain in the bed. Okay, life-threatening hyperkalemia, it's always be a good idea to use conventional or intermittent hemodialysis, and dialysable intoxications such as metformin or lithium, for example. It will be better with high efficiency therapies. Okay, so final thoughts. AKI in the ICU that requires kidney replacement therapy has very high mortality. We know that from 2 decades ago. To this day, there is no evidence to support a particular type of kidney replacement therapy in patients with AKI in the ICU. Efforts should be focused on solute control and fluid balance. Kidney replacement therapy of choice should be based on technology and experience available. And if all types of kidney replacement therapies are available, special clinical scenarios should be considered in the choice of kidney replacement therapy type. And thank you very much. I will be glad to answer your questions.
Muchas gracias. Thank you very much. Good overview, short, but clearly very interesting. So let's take a few questions now. We have about 10 minutes left. And perhaps to Wojciech first, you described very well the frailty score, but many of us do not use the score routinely, exactly as we do not use the SOFA score routinely in our ICU. So do you think we should really refer to the score, not only in pandemics, of course, when there are triage issues, but when we have beds available in the ICU? You say that it may influence the ethical decisions. Do you really use a score for such very important questions?
So Professor Vincent, absolutely not for as a single thing. It's just like a broad spectrum of a whole patient, and frailty is one of them. So if you have comorbidities, if you have a long disease, long time in hospital, older patient, and frailty 7 or 8, this would definitely be a sort of like, for me, another evidence that probably our treatment will only add suffer. So I actually use it for triage or for time limited trial or decision of other investigation or actually how to treat the patient. So yeah, I use it, but never as a single factor. So you remember pandemia, there was thought about 4 or 5 cutoffs. It's definitely not good. Yeah.
Absolutely, very good. So we may come back to you if there is another question for you, but Marta, Velia, you are a perfusionist, I believe. And the question is, do we really need ECMO centers, or do you think we could apply ECMO in every single institution? Especially after the COVID experience, the use of ECMO has been more widely applied. What do you think will be the future? Shall we go back to ECMO centers, or shall we have many centers using ECMO? Please.
I think the best option is to have regionalize it more, something better than the hub and spoke model, with the referral centers providing both support in situ and their hospital for the ECMO patients. So when you have a standard condition, so no pandemic and no increased demand, you could centralize the patient and provide better support, because you are going to provide the better experience and a more experienced team to the patient. But if you have an increased demand, you could provide NEC2 support to other centers of your network. I think this is better. But the lower the center, the better the support for the patient in normal situation, apart from pandemic.
Do you think that future technologies may change your answer if there is telemedicine available that could help people locally with their technical problems or very precise problems that you could overlook with a good camera, looking around at the bedside and interacting with the players at the bedside?
Yes, but we have some technical complication, some practical complication on ECMO that require immediate intervention from experienced providers.
Yeah.
So it's not enough. It's not enough.
All right,
and
very good.
Complication could be unpredictable, unfortunately.
Sure, it's better to have someone who is knowledgeable and well-trained at the bedside. Very good. Alessandro Belletti, about the vasoactive agents, we have actually many questions. Let me ask a few of them, but we will need some short answers. Someone asks, should we titrate vasopressin somewhat, or should we use a single given dose to every single individual?
I think that, and that's also what we do, to titrate according to individual response is generally better. I don't think that using a fixed dose for everyone is a good approach in general. Of course, it's simpler, but I think it's maybe better to use maybe we can use a kind of hybrid approach to move across a certain range and adjust the dose according to individual response, rather than using a fixed dose. That's my opinion.
But how would you assess the response? By blood pressure? Is there no risk at giving relatively high doses of vasopressin?
Yes, indeed. So high doses of vasopressin will increase the risk of mesenteric and, for example, digital ischemia. So it may reduce the risk, for example, of arrhythmias, but may increase other side effects. So the question remains, if you need to go very high on vasopressor overall, remains whether your strategy overall is correct, or whether you should switch strategy in general.
Okay. Okay. Is dopamine definitely out, or do you see it used in some particular patients, for instance, those having a relatively slow heart rate?
We do use it like that. So in patient, so I work in a cardiothoracic ICU. So when we want to increase heart rate, and for example, patient for some reason do not have the pacemaker wire, for us it's very good to have it. And we do use sometimes dopamine to increase heart rate. So we use dopamine as a chronotropic agent. So my answer is yes.
What is the best place for angiotensin II?
So here we start to have a little bit more answers. So for example, as I showed in my presentation, there now could be the possibility to potentially predict the response to angiotensin II by dosing the renin level. And that could be a possible option in the future to be investigated. Again, if you want to reduce the dose of norepinephrine for sure, and potentially limiting arrhythmias or side effect of norepinephrine, that could be another option. And another interesting approach, but even though now it might be outdated, could be also in COVID patients, as also recently seen that ACE inhibitors worsen outcome of COVID patient. Maybe angiotensin II may have the opposite effect, but hopefully this will not be a problem anymore in the future.
You said combination therapies could be valuable. Someone asks, when would you start something else than noradrenaline in particular? Do you just look at doses of noradrenaline, or do you look at something else?
Being 100% honest, we generally do look at dose. However, the question always remains if, so we add another vasopressor if we are really sure that the only problem of the patient is excessive vasodilation. You know, whereas the first question you should ask yourself is, do I need such high dose of norepinephrine? So why do I need such high dose of norepinephrine? Is the patient just vasodilated, or there is something else going wrong that I missed? So low cardiac output, or hypovolemia, or is patient bleeding somewhere, or so on. And only if the answer to all of these questions is no, and the dose is above, let's say, 0.5 micrograms per kilogram per ml of norepinephrine, I think it's reasonable to add a second vasopressor.
Thank you. Now let's move to the kidney. Pablo, several questions for you too. Is there still a place for peritoneal dialysis?
Well, of course, there's a place. We use it every day. It's our first. We have all the options. We have hemodialysis, we have peritoneal dialysis, and we have continuous renal replacement therapies. And our approach is to start asking if the patient is viable to acute PD. Normally, the most difficult part for peritoneal dialysis is the cath installation, but we use a percutaneous approach, ultrasound guided, modified, and we can start the treatment 20 minutes, immediately after putting the cath. We have cyclers, so it's kind of a continuous renal replacement therapy. And when the abdomen or the peritoneum is not viable, we use continued renal replacement therapy, or even prolonged intermittent renal replacement therapy. So it's completely viable. We do it every day, and maybe it's kind of forgotten, but we have not forgotten here in Mexico, at least.
Yeah, because in many places, peritoneal dialysis, as you say, it has almost disappeared. Now, yes. in shock states, do you always use hemofiltration, or would you use dialysis?
No, I use, normally I try to, when I use extracorporeal continuous renal replacement therapies, I try to prioritize the circuit. So for me, the most important part is to prioritize the circuit. So there's no evidence that using convection to the doses that we use today have proven to be better. So when you use convection, normally you stress the circuit with PTM elevation or hemoconcentration that can reduce the time or the circuit time. So normally we use a continuous hemodialysis. We use a regional citrate anticoagulation, and we can have circuits that can last for many days, even out of the counter recommendation. We can last filters for 7 or 8 days without changing them because we use all this part. We always prioritize circuit instead of modality. Okay.
Now, you presented so well the different possibilities. Do we still need a nephrologist for that particular aspect to choose among the different types of renal replacement therapy and or to decide to change from one type to another? Is a nephrologist useful there?
Well, it depends in your setting. There are nephrologists. Well, I am a nephrologist, so I will say yes. But normally, sometimes inside nephrology, this is a part of nephrology that nephrologists aren't very interested in. They are interested in something else. So I will say that in some settings where nephrologists are not totally involved in the ICU, it's totally viable that ICU doctors will have a word and decide on this, especially if they dominate the kinetics and the technical parts. Especially that I will not say that nephrologists are exclusive of the replacement therapy in the ICU. Okay, but depends the setting. Okay. There are some settings where maybe it will be the thing. I will argue for the multidisciplinary approach.
Okay, and maybe a last question for you. Someone asks if the patient on renal failure and on renal replacement therapy can keep some diuresis. Should we try to keep it by all means by using diuretics, or we just give up and wait?
No, totally. If the patient has kidney residual volume, that means that kidney can still help in the replacement therapy. So it will reduce considerably the ultrafiltration we needed or the fluid removal that we need to put to the machine, and we will use the patient as a diuresis. We know now that diuretics are not nephrotoxic, or they don't cause any damage on the kidney directly. So if the kidney is responding, we can give it a push with that diuretic without doubt.
Yeah, well, yeah, I suppose some people would challenge it and say that diuretics may not help so much if there is renal failure, and even if it does not alter kidney function, maybe it could decrease the auditory function if you use furosemide, right? You are not concerned about hearing losses with furosemide?
Well, not really. The studies about ototoxicity related to furosemide they were reported in kids with very high doses that we don't use right now. Even at very high doses, like 1 gram in 24, it's not the total dose that cause ototoxicity, but more the concentration and the speed to the body that can cause ototoxicity. It's very rare that with the doses, even high doses that we use right now, patients will get ototoxicity. So it's really not it's not a concern right now with the doses that we use, and probably there will not be any concerns for me by using high dose.
All right.
Yeah.
Very good. Now our participants have a last chance to raise a last question, but I skipped some and I will go back. Perhaps a question to Alessandro. Someone asks, would you use methylene blue in some patients? Methylene blue is coming back, and people wonder whether they should use it or not.
We do use it. So my answer again is yes. So we do use as a catecholamine sparing agent. So apart from patients with favism, which is relatively common in Italy, but we generally do use methylene blue. And I think that there was one recent study that did not show, but shows some efficacy in improving again blood pressure, reducing catecholamine. Those also methylene blue use will increase in the next few years, I guess.
Well, yeah, we need to see the trials because it can be a very dangerous intervention too. It's not because it raises blood pressure that is necessarily good. So I guess we will need some additional data on methylene blue. Yeah. Well, you know, I look at our watch and it's already 6 minutes past 5. We started a bit late. That's the reason why I allowed the time to go a bit over our schedule. But now it's time to bring it to an end. And sorry again for the technical problems at the beginning. But I think we had good presentations and very good discussion. So I would like to thank you all, speakers and the about 150 participants, for having been with us. It was certainly an interesting discussion. Take care. Bye-bye.
Thank you.
Thanks, everyone. Thanks for the invitation.